Good afternoon, everyone, and welcome in. I see we have a lot of people coming in today to join us for this webinar. Thank you for joining the PHA live webinar, Managing Scleroderma and Pulmonary Arterial Hypertension. We appreciate you taking time out of your day to participate in this webinar. I see a majority of those registered have joined, so we will go ahead and get started. So again, thank you for joining Managing Scleroderma and Pulmonary Arterial Hypertension webinar. Next slide, please. We also would like to take a moment to thank our partner, the National Scleroderma Foundation, for joining us in this collaboration for this amazing opportunity to hear from our speakers. Thank you again for this partnership and collaboration. Also, we would like to take a moment to thank our PHA Connects sponsors program. To thank our PHA Connects program sponsors. Sponsors do not participate in the development of and do not endorse the content of programming. We appreciate their support. Also, we invite you, whether you are living with pulmonary hypertension or assisting in treating and managing, to become a member of the world's largest organization focused on raising pulmonary hypertension awareness, empowering and supporting patients, building meaningful connections, and of course, finding a cure. If you are interested in participating or becoming a member, please reach out to memberships@phassociation.org. And before I turn it over to our wonderful panel today, I would like to go over some programming notes with you. We will have Q&A immediately following the presentation from our panel. You can use the toolbar, the Q&A button on your toolbar to be able to access and submit questions to our panel. And then also at the conclusion of the webinar, there will be a survey for you to complete. We ask that you take this moment to fill out this survey so that we know what you would like to see in the future and that we can get your thoughts on this wonderful presentation. And so now I would like to move on to showcase and introduce our panel. We have a lovely guest for you today to discuss scleroderma and pulmonary arterial hypertension. I will take a moment to allow them to introduce themselves now. Dr. Crespo, we'll start with you.
Yeah, hello. My name is Maria Crespo. I'm the medical director of the Transplant program at the Hospital of the University of Pennsylvania here in Philadelphia. And it's a pleasure to be here in this webinar today. Thank you.
Yeah, thank you so much. And Dr. Mathai, we'll go with you to introduce yourself.
Sure. Hi, my name is Steve Mathai. I'm part of the Pulmonary Hypertension program at Johns Hopkins, and I'm very excited to be here.
Perfect. And of course, Neal, we are so lucky to have you here. Neal will share his journey with scleroderma and PAH. Neal, introduce yourself and take it away.
Hi, folks. My name is Neal McDermott, and I live, work, and play in the mountains of Tucker County, West Virginia. This area is widely recognized as a playground for the outdoor athletes. Prior to developing symptoms of scleroderma, myositis, and pulmonary arterial hypertension, I considered myself to be an outdoor athlete. I used to be able to leave my job as a custom woodworker and get on my mountain bike and ride till dark, or put on a headlamp and go for a moonlight cross-country ski. I'd spend weekends at our local rock climbing area. This all changed when symptoms showed up around 2006 with white fingers that I attributed to vibration from my motorcycle handlebars. And I had had white fingers happen several times skiing, but never when it was 80 degrees out on a hot sunny day. Later on, I went to develop sores on my fingertips, which kept me from the sports I love to do and really affected my ability to work with my tools. I started to experience muscle loss that made all my tools feel like they were gaining weight. I started to have shortness of breath in 2010 as I could no longer do nonstop flights of stairs or ride my mountain bike at all. My employees started noticing and asking if I was doing all right. Basically saying that I wasn't able to hit it like I used to. I would sit at my kitchen table Googling images of sores on fingers when I saw what looked like mine. My wife would often tell me to turn off the computer, saying every time you look at that, you think you have something new. But I was on to something. My best friend and primary doctor, Ed Rader, saw my decline and started ordering tests. We did this at the end of my kitchen table, and he saw that I couldn't climb anymore. He saw I couldn't ride anymore. He saw, I was really lagging behind. And so my diagnosis came, unlike many others that are misdiagnosed or underdiagnosed for long periods of time. Mine happened at my kitchen table. In 2012, I took a job teaching building construction at a local high school, hoping this would be easier on my body than running my own business. My fingertips were so bad that the school couldn't run my fingerprints for a background check. In 2016, the symptoms got worse to the point that I could barely push an empty wheelbarrow from our barn to our house. It was then that my primary doc referred me to Dr. Julie Pack at the Johns Hopkins Scleroderma Center, where I was diagnosed with limited scleroderma and subsequently referred to Dr. Mathai at Hopkins Pulmonary. A month after my first clinic, I had a right heart catheterization that resulted in my diagnosis of severe pulmonary arterial hypertension. Fortunately, this was shortly after the results of the Ambition trial showed the benefits of combination therapy for newly diagnosed patients. I was put on ambrisentan and tadalafil and have been on it since. In 2018, I applied for and received scholarships to attend both the PHA and National Scleroderma Foundation conferences. At the PHA conference, I sat at a dinner table and introduced myself as someone who's never met anyone with scleroderma or PH. At that very same table was Debbie Drell, a former contributing member at PHA. She told me then that my rare disease isn't so rare in this room and proceeded to introduce me to about 200 people that she knew on a first name basis. A similar eye-opening event happened a month later at the National Scleroderma Foundation conference. I can't say enough about the benefits of having attended these conferences. It offered a whole lot more than a meet and greet. Between 2018 and 2022, I was pretty stable. But after a right heart cath in early 23 showed my pressures to be higher than when I was first diagnosed, Dr. Mathai started me on a third therapy, Uptravi, and began the conversation about considering early evaluation for lung transplant. That one took me for a loop. I went home and started to research all I could about the transplant process and found myself getting discouraged by the number of limitations before and after transplant. I got to thinking I didn't want to subject my recently retired wife to being a full-time care provider. I did ultimately decide to go ahead with the evaluation and am currently working with Dr. Jason Turowski at the Cleveland Clinic. I wasn't sold on the idea of being transplanted till I was visited by a friend that I knew was very sick with sarcoidosis. The last time I saw him was years ago, and he was on oxygen and looking pretty bad. But here he was in this very same shop walking in and looking great. He said he was on his way to go mountain biking. He had had a double lung transplant at Cleveland Clinic 3 years ago, and he really did look great. We sat for hours and he told me all about the process. He had great things to say about his new lease on life. He's back to snowboarding, climbing mountains, and mountain biking. He's a huge inspiration and a major reason my thoughts are all positive as I move forward with the evaluation process. And I truly do appreciate the opportunity to share a little bit of my story with you folks. I benefited from reading and seeing other people share their stories. And when Dr. Mathai asked me if I would consider to share mine, I didn't hesitate. And I hope that those in the audience with a story to share do the same when they have that opportunity. Thank you.
Well, thanks so much, Neal. Really wonderful and powerful story you're sharing, and I appreciate your willingness to do so. We all do. I will now present my slides on pulmonary hypertension. Just give me 1 second to load my slides here. All right. Right. So what I'd like to do today is go over some of the definitions of pulmonary hypertension, how we diagnose the disease, how we treat the disease, and then talk about the impacts of pulmonary hypertension. And I'll try to focus this on scleroderma so we understand the similarities, but also the differences between this form of pulmonary hypertension and other forms of pulmonary hypertension. So the first thing I'll answer is, what is pulmonary hypertension? In its simplest form, pulmonary hypertension means elevated blood pressure in the lungs. And importantly, this can happen whether or not you have regular high blood pressure. So if you have hypertension, it doesn't necessarily mean you're at increased or decreased risk of developing pulmonary hypertension. The reason this is important is that the high blood pressure in the lungs can put strain on the heart. And when I have the asterisk there, that refers to the fact that usually the strain that is placed on the heart from pulmonary hypertension is focused on the right side. And this strain can ultimately lead to heart failure. So the definition of pulmonary hypertension from about 1993 to 2018 was the average or mean pressure in the lungs greater than or equal to 25 millimeters of mercury. Why did it change in 2018, or what happened in 2018? Well, at the 6th World Symposium of Pulmonary Hypertension, which is a global entity that meets every 5 years to discuss the advances that have been made in the diagnosis, treatment, and evaluation of patients with pulmonary hypertension, they convened and decided that they were going to lower the pressure threshold from 25 to 20, greater than 20 millimeters of mercury. And when I was at the meeting, and when I was there, this cartoon popped into my head, and it said, "Good news, your cholesterol has stayed the same, but the research findings have changed." And there was a lot of uncertainty about what the impact of this lower threshold of pulmonary pressures definition would be on our patients who are at risk for pulmonary hypertension, such as those with scleroderma. So in 2018, as I mentioned, the pressure threshold was dropped to greater than 20 millimeters of mercury, so 21 millimeters of mercury and higher. But later in 2022, the European Respiratory Society and European Society of Cardiology proposed that a pulmonary vascular resistance of greater than two Wood units be included in the definition of pulmonary hypertension. And in fact, this was adopted at the 7th World Symposium of Pulmonary Hypertension that occurred back in June of this year. So the new definition of pulmonary hypertension includes not only a mean pressure of greater than 20, but also a PVR of greater than 2 Wood units. And I'll talk a little bit more about this in a couple of slides. So why is that important for patients who have scleroderma? Well, this is an older study looking at what happens to patients who have a mean pulmonary pressure in that 21 to 24 range. So patients who at the time of 2013 would not have been diagnosed with pulmonary hypertension, but had mildly elevated pulmonary pressures. In this study, normal pressures were defined as a mean pulmonary pressure of less than or equal to 20 millimeters of mercury. And as you can see here on this graph, we look at the patients who had a mean pressure between 21 and 24. Over the next 5 years, there was an increased risk of those patients, a nearly fourfold increased risk of those patients developing or progressing to pulmonary arterial hypertension, which is defined as a mean pulmonary pressure of greater than or equal to 25 and a PVR greater than 3 Wood units. So this lower threshold of pulmonary pressures seems to capture a clinically relevant group, an important group for us to consider, particularly for those with scleroderma. So to put this into a graphic so we can understand better how pulmonary hypertension is defined, we described a mean pulmonary pressure of greater than 20 millimeters of mercury. And then when we think about pulmonary arterial hypertension, we have this category here of precapillary pulmonary hypertension, where you not only have a mean pressure greater than 20, but also a wedge pressure less than or equal to 15 and a PVR greater than 3 Wood units. Similarly, we have post-capillary pulmonary hypertension, where the pressures in the lungs may be a little bit elevated, but the pressures on the heart, the left side of the heart, are also elevated. And then we have an overlap between those two, where we have high pressures in the lungs, high pressures on the left side of the heart, and also high resistance in the heart and lungs. So this is said a little bit tongue-in-cheek, because I know I've explained or demonstrated a couple things that are pretty complicated. It actually is even more complicated when we try to figure out what to do about these patients. So when we think about treatment of patients who have pulmonary hypertension, we not only think about their numbers, i.e., what are their pressures, both in the lungs, in the left side of the heart, and what is their pulmonary vascular resistance, so essentially how hard it is for blood to get through their lungs. But we also think about what are the potential factors that are contributing to that elevation of pulmonary pressures. So this table here shows the many different forms of pulmonary hypertension, or the things that can be associated with pulmonary hypertension, and the clinical classification that we use to organize these patients in our clinical practice. And this is important because depending upon where you fall in this table, it dictates the appropriate therapies for you. So I'll put it in a figure, which may be a little bit easier to comprehend. We have group 1 patients up in the top left here, pulmonary arterial hypertension. And that means you have elevated pressures in your lungs, normal pressures on the left side of your heart, and an elevated pulmonary vascular resistance, but you don't have any of these other diseases that are listed here. And I'm going to talk about each of those in more detail. On the bottom here, we have patients who have pulmonary hypertension related to left heart disease. Now, that is by far the most common cause of pulmonary hypertension. 80% plus of patients who have pulmonary hypertension, it's related to something going on at the left side of the heart. So that's an important thing to evaluate, because again, where someone is classified clinically determines where they're going, how they're going to be treated, with what medications might be available or other strategies. Group 3 pulmonary hypertension is patients who have underlying lung disease as the cause of pulmonary hypertension, whether that's COPD, which is usually related to cigarette smoking, interstitial lung disease, fibrosis of the lungs, which the patients with scleroderma are familiar with that complication related to scleroderma. Sleep apnea can cause pulmonary hypertension, etc. We have group 4 on the bottom left here, and these patients have chronic thromboembolic pulmonary hypertension. So those are pulmonary hypertension related to chronic blood clots that can form in the lungs. And then group 5 is kind of a hodgepodge of other diseases or disorders that can be associated with pulmonary hypertension through multiple different mechanisms. So why is scleroderma so challenging? It's challenging. I'm going to talk about this on the next couple of slides, because it is fairly common and it has multiple different forms of pulmonary hypertension. So first thing to know is 8 to 12%, and some reports up to 15% of patients with scleroderma will develop pulmonary hypertension. But I specifically said pulmonary hypertension because there are multiple different forms of pulmonary hypertension that can be associated with scleroderma. And I'll come back to that in a second. Scleroderma, as we know, affects the lungs, the heart, and the kidneys, all of which can lead to pulmonary hypertension. And then the scleroderma itself causes changes in the structure and the function of cells that are involved in the development of pulmonary hypertension. One way to think about this, and although it's not exactly what we think happens, but the similarities that occur between Raynaud's phenomenon, where your fingers can turn white or blue or become painful when exposed to cold air or cold water, similar phenomenons might occur in the lungs. So I just showed you this figure, but I want to come back to this to highlight the multiple different ways scleroderma can be associated with pulmonary hypertension. So patients with scleroderma are at risk of getting pulmonary arterial hypertension. They can have a rare form of pulmonary arterial hypertension known as pulmonary veno-occlusive disease. They can have lung disease commonly, interstitial lung disease in particular, that can lead to pulmonary hypertension. They can have left heart disease. It is very common for patients with scleroderma to have diastolic dysfunction leading to pulmonary hypertension. They can have blood clots in their lungs that lead to pulmonary hypertension. And they can have multiple different mechanisms, either related through renal disease or other organ involvement that can lead to pulmonary hypertension. So you can see how scleroderma might be a more difficult or challenging disease in which to properly classify and diagnose pulmonary hypertension. So the next thing I'm going to talk about is the diagnosis of pulmonary hypertension. So how do we check for it? Well, once you've been diagnosed with scleroderma, your rheumatologist or pulmonologist or cardiologist, whoever's following you for your scleroderma and potentially for pulmonary hypertension, will get yearly pulmonary function testing. And this is ostensibly to screen for interstitial lung disease, of which up to 90% of patients with scleroderma will develop interstitial lung disease, but it's also to screen for pulmonary hypertension. A yearly echocardiogram is recommended for evaluation of pulmonary hypertension and yearly blood work. So what are we looking for? In pulmonary function tests, we're looking for a drop in diffusing capacity for carbon monoxide. So this is one component of pulmonary function testing. And it's important to note that this is obtained through one of three of the commonly ordered components of pulmonary function tests. So you have spirometry, lung volumes, and diffusing capacity. So you want to make sure that you're checking diffusing capacity as well on a yearly basis to understand what's going on with this component. We're looking not only for a drop in diffusing capacity, but also for a change in the ratio of the forced vital capacity, which is a measurement of essentially how big your lungs are, to the diffusing capacity, which is a measurement of how easy it is for oxygen to get from the air into your bloodstream. On the echo, we'll be looking for signs of elevated pressures in the lungs, abnormal size, shape, or function of the heart chambers, and for fluid around the heart. And blood work, a couple of things we might be looking for include an elevated NT-proBNP, which is a blood test that assesses for strain on the heart. And in the right patient, someone who's at risk for pulmonary hypertension can suggest evolving pulmonary hypertension. And elevated uric acid, which is oddly enough a test we think of when we're trying to diagnose gout, but also has been associated with the development of pulmonary hypertension. So here's the key thing when talking about pulmonary hypertension. It's important, as I mentioned, to understand that scleroderma can predispose to many different forms of pulmonary hypertension. So getting a thorough workup is really important. But pulmonary hypertension can really only be diagnosed with a right heart catheterization. So until you have a heart catheterization, we cannot know for sure whether you have pulmonary hypertension, what form of pulmonary hypertension you have, and how best to treat it. So what is a right heart catheterization? Well, here's a cartoon figure demonstrating what a right heart catheterization entails. Essentially, we put an IV in a large vein in your neck, and through that IV, we thread a catheter that has a probe in it, or at the end of it, into the inside of your heart and out to the blood vessels that connect the heart and the lungs. And through that catheter, we can measure pressures in your heart, pressures in your lungs, and how much blood your heart pumps each minute. With those values, we can calculate that PVR, or pulmonary vascular resistance, that I was referring to earlier. Other tests that are absolutely necessary to properly classify patients into one of those 5 groups that I spoke about earlier, a ventilation perfusion scan is exceedingly important. Not just a CAT scan, but a ventilation perfusion scan, which is a scan of the chest that looks for old blood clots in the lungs. A 6-minute walk test to assess whether or not your oxygen levels drop when you walk, but also to assess how much your breathing is impairing your ability to walk. Blood work, and a sleep study if there are symptoms of sleep apnea or sleep disordered breathing because of its association with pulmonary hypertension. So how is pulmonary hypertension treated? Well, it really depends. And it depends on the type of pulmonary hypertension you have. So whether you're in group 1, pulmonary arterial hypertension, there are medications approved by the FDA to treat pulmonary arterial hypertension. There are medications that are approved to treat pulmonary hypertension in the setting of interstitial lung disease and also chronic thromboembolic disease. When we think about pulmonary hypertension related to left heart disease or in multifactorial situations where you have renal disease or other contributing factors, there are no recommended therapies. So this is why it's so important. And in fact, some of the therapies that are used to treat pulmonary arterial hypertension applied in patients who have left heart disease or renal disease can be harmful. So it's really important to make sure that you have a proper and thorough evaluation to properly categorize and classify your disease. So as I mentioned, the grouping really informs or teaches us how best to treat patients. So if you have group 1, 3, or 4 disease, medications are available or other interventions are available. Groups 2 and 5, we have to focus on the underlying cause rather than the pulmonary hypertension itself. Other things that may come into play include patient preference. So there's different routes of administration of medications. Some are pills, some are injections, some are inhaled. Some are twice a day, 3 times a day, once a day. These are all things we have to think about. And that involves a good conversation with your providers to make sure you understand the risks and benefits of each of the potential approaches. And then other considerations such as drug-drug interactions. Are you on other medications? Are the interactions between the medications you're taking and the medications that we're considering to use for pulmonary hypertension are important? And obviously cost and other factors are going to be considered. The severity of pulmonary hypertension is really important and often dictates our recommendations as physicians about which medication should be used. So how do we understand severity of pulmonary hypertension? Well, often what's done now is applying a risk score, and there are multiple different calculators out there that providers are using these days to understand someone's risk. I'm not going to go through all of them, but essentially one way of thinking about this is if you're low risk, 1 oral agent is sometimes considered sufficient. If you're at intermediate risk, 2 oral agents is considered as a sufficient strategy when you're starting therapy. And then if you're high risk, intravenous medications plus or minus oral agents are also recommended. How do you assess response? Well, over time, you're going to have a baseline echocardiogram, a walk test, and blood work. And then our practice, and I think this is pretty standard across the field, is 4 months after starting therapy, you'll repeat the echo, walk test, and blood work. And if things look better, you'll follow up every 3 to 4 months. And about once a year, you get a repeat echo and walk test and blood work just to make sure things are moving or stationary or improving. If there's no improvement, or then a repeat heart catheterization will be considered to see if the medications are doing what we're hoping they're doing. And if not, another medication may be added. And then if there's progression of pulmonary hypertension, this is the time where we start thinking about lung transplantation. Another predictor, another thing we consider is if someone presents with severe pulmonary hypertension at the time of evaluation, at that point, we would in parallel not only start therapy, but also refer for lung transplantation. So what about the impact of pulmonary hypertension? Well, worse functional capacity is something that we see. Patients notice shortness of breath, problems with walking, problems getting up a flight of stairs, as Neal was telling us about earlier. Quality of life definitely deteriorates when you have this because it's harder to do things, and you feel short of breath when you're trying to do certain activities. There's obviously a higher risk of hospitalizations because of the development of pulmonary hypertension, and obviously, unfortunately, a higher risk of death with pulmonary hypertension as well. So what are we thinking about? What are we looking forward to in the diagnosis and treatment of pulmonary hypertension as providers? Well, I think the screening tools and treatment regimens that are currently in place are all based upon that pH definition that I showed you that changed in 2018, where that mean pulmonary pressure threshold was set at greater than or equal to 25 millimeters of mercury. So understanding the best strategies to identify patients who have a lower threshold or fulfilled the diagnosis of pulmonary hypertension at a mean pulmonary pressure of 21 to 24 is going to be important. But the next step is also thinking about how we're going to treat those patients. So all the studies that were performed, all the drugs that have been approved to treat pulmonary hypertension were studied in patients who had a mean pulmonary pressure of greater than or equal to 25 millimeters of mercury. We're not sure whether these medications will be effective, safe, tolerated in patients who have a lower pulmonary artery pressure elevation. I'm going to spend a minute just talking about this newly approved drug called sotatercept, which is a new drug approved to treat pulmonary arterial hypertension. And I'm going to talk a little bit about some of the unique aspects that might be related to scleroderma. So this new drug, sotatercept, was just approved in March of this year. And in the field, it's an exciting development because it is a new mechanism of action. All the currently approved medications up until this approval of sotatercept were focused on dilating blood vessels. So it was important to dilate the blood vessels to improve blood flow into the lungs and reduce the pressure on the heart. This medication, we think, again, we can't prove this in humans, but in our models of pulmonary hypertension in animals, what we think happens, what we see happening, is that the vessels themselves remodel, meaning that the abnormal cellular growth that is a feature of pulmonary arterial hypertension that causes the narrowing of the blood vessels in the lungs, that process is reversed with this medication, which in turn reduces the pressures and improves heart function. This medication is delivered subcutaneously. It's an injection every 3 weeks. There are some side effects, as with any medications, as low platelet counts. Oddly enough, your hemoglobin can rise with this medication. This medication was first developed to treat certain forms of cancer that were characterized by low blood counts. So it seems to improve that, but almost contradictory seems to be associated with bleeding too. So nosebleeds and gastrointestinal bleeds. Telangiectasias seem also to be more prevalent, and in patients who even didn't come in with telangiectasias, who were started on the therapy, this also seems to happen to those patients. So I've underlined these things here, which I think are relevant to our scleroderma patients who have propensity for nosebleeds, for gastrointestinal bleeds due to involvement of the GI tract in scleroderma, and then obviously the telangiectasias component is important. What we don't really know about sotatercept yet is its tolerability and long-term effects in our scleroderma patients in particular. For whatever reason, the initial study that was conducted in sotatercept, only about 15% of the patients enrolled in the study had scleroderma. In most clinical trials of PAH therapies, that number is closer to 30 to 35%. So not only do we have a lower number of patients that studied on the drug, but it's important for us to then follow those patients carefully to understand if there are any unique side effects that might impact its tolerability and effectiveness in patients with scleroderma. So in summary, pulmonary hypertension is elevated blood pressure in the lungs. There are many forms of pulmonary hypertension. Proper diagnosis can only be achieved with right heart catheterization. Treatment of pulmonary hypertension varies by type of pulmonary hypertension and severity of pulmonary hypertension. And then future studies will look to identify and treat patients with less severe disease. So with that, I thank you for your attention and look forward to the question and answer session at the end of our program here. And I will stop sharing.
Can everybody see
Yes.
We may have some technical difficulties here. We experienced that earlier. While we are waiting for Dr. Crespo to come back, I want to thank you both, Neal, for sharing your story. I think
Evaluation to
Dr.
listen.
Crespo is back.
We lost you there for a second.
Okay.
Maria. Yeah.
Okay. Yeah, I think that my connection is not the greatest. Yeah. Also, some of the unique consideration and challenges that the scleroderma patient faces during the lung transplant evaluation. Some of the data on the lung transplant outcomes, as well as the updated guidelines on lung transplant evaluation and candidacy. Like we have heard, renal failure used to be the most common cause of death. However, pulmonary fibrosis and pulmonary hypertension are currently the most common causes of death, and sometimes they lead to the need for a lung and at times actually a combined heart and lung transplant referral. So the lung transplant journey from the pre to post transplant can be overwhelmed and very exhausted and stressful, not just for the patient, but also for the caregiver. And the lung transplant programs will offer actually all the education and resources that the patients and the families they need. It's very important that patients actually have a very good understanding of what to expect during the evaluation, the wait list, and the post-transplant. When a patient is referred for a lung transplant program, one of the things that we check first is that how sick the patient is. And if the patient is not so sick, I mean, then we actually initiate what is called like a routine a clinic visit, where we focus mainly on the lung transplant education and what to expect. On the other hand, if the patient has an urgency assessment, then we will determine whether this patient will need to have a expedited transplant evaluation as an inpatient or either as an outpatient. The outpatient is between 4 to 5 days to complete all the testing required. Patients also will, once the evaluation is completed, I mean, those patients, they will be presented at the multidisciplinary transplant selection committee. And if they are considered, adequate for list, they will be listed and have a lung allocation score, which is called a CAS scoring system, which I will discuss a little bit more later on. Patients that they are listed, I mean, the clinical status can change, so that's why they are going for a close monitoring all the time, at least every 3 months. And this is the multidisciplinary team approach in lung transplant evaluation. I mean, like you see it in the center, the patient, and these are all actually like the team that participated in the transplant evaluation, not just the medical team including the pulmonologists, the surgeons, and the nurse practitioners and the coordinators, but also the social worker, the transplant finance person, the respiratory therapist, speech and language pathologist, as well as the PTOT, the transplant nutritionist, and it's important also the palliative care and the support groups, which, as I mentioned, it can be very stressful, all this evaluation for the patient as well as the families. We have in here also the different transplant consultants, and I highlighted in yellow the gastroenterologists, cardiologists, and rheumatology. That is important for scleroderma patients whenever they are evaluated, just because of the extrapulmonary conditions associated with scleroderma. So these are all the serologists. I mean, they are important as part of the transplant evaluation. So patients, they go through a thorough laboratory testing, making sure that they don't have any unusual anemia, making sure that the liver and the kidney function is adequate. Patients, they will have a blood group check because they will be matched with a donor from the same blood group. We want just to make sure that particularly patients that they were previous smokers, that they are not actively smoking. Patients, they will have a pregnancy test. We will want just to make sure that the patient, they have what is called a calculated PRA, just to assess the immune system antibodies of a candidate and to make sure how difficult it's going to be to match with a donor. Also, we want to assess the prior or current infections of the patient, the breathing test with the pulmonary function test, like you all know, arterial blood gases. I mean, not to make sure that the patients, they are not now even actually like developing worsening hypercarbia or with increasing the PCO2. And also we assess the 6-minute walk test. We do cardiac studies like indicated in here. Not all patients, they require a cardiac MRI, but some patients with scleroderma, they develop a condition which is called myocarditis. And this is the best test just to properly evaluate these patients. These are all the imaging studies, vascular studies, to make sure that there are no significant carotid stenosis or peripheral vascular disease, but that we only do in patients depending on the age and risk factors. We want just to make sure that the patient's bones, they are good, because they are going to be after the lung transplant or high doses of steroids. So we want just to prevent that patients that develop fractures, but also we will make sure that the patients, they have all the screening for cancer relevant to their patient's age. And this is all the importance, the GI studies, particularly with patients with scleroderma. We need to assess the gastric, esophageal reflex and motility, as well as the gastric empty study. And these are all the different testing. Why the small bowel? Because we want just to make sure as the risk stratification, what is the underlying severity and extension of the GI involvement related with the scleroderma, and also to guidance on the management of these patients post-lung transplant. Here, actually, like also, I wrote the endoscopy, which unfortunately some patients that they are very sick, either they have severe pulmonary hypertension and they are on high flow oxygen, they are not going to be able to tolerate the endoscopy due to the fact that it's going to be very risky, not just the procedure, but put them through anesthesia. But it's important, otherwise in patients that they are stable and they have had a prior history of Barrett's disease, just to make sure that they don't have any, on the biopsies, any severe dysplasia or even signs of possible esophageal cancer. So what is the CAS scores that I mentioned before? That is the lung composite allocation system, and what factors make up the lung CAS. So the CAS was initiated or implemented back in March of 2023. So we have been using this for the lungs over a little bit over 1 year. And there in here actually like 5 factors that they are important. One is the medical urgency, how sick they are the patient. And that was actually with the aim to reduce the mortality while waiting for the transplant. The other one is that what is actually the anticipated post-lung transplant outcomes, how what is the patient is going to be able to survive more than 5 years. Also, contrary to the other allocation system, the LAS, here the CAS included the biological disadvantage, giving the opportunity of patients that in the other system, they have challenges getting a transplant soon, either because of the blood type, either because they were very sensitized or because of size issues, and also patient accessibility, particularly actually patients that they have less than 18 years old. So the aim or the goal of this lung CAS, it was just to prioritize sickest candidates first to reduce the wait list death. Also to improve the long-term survival after transplant and increase the transplant opportunities, as I mentioned, for patients who are medically harder to match. Increase the transplant opportunities for other candidates, particularly candidates that they are younger than 18 years old. So in general, to promote the efficiency of managing the organ placement. So this is actually like the score points. I mean, that they are distributed, and as you can see, the majority of them is the candidate medical urgency and the likely survival of more than 5 years. So what are the tests and observations that they are used to determine the urgency and expected survival? In here, they are all these. Is patients that they have higher pulmonary artery pressures. I mean, that means that they have worsening pulmonary hypertension. They're the sickest ones, and they have this medical urgency priority. How much oxygen is the patient on, the age, BMI, how sick is the patient, and you can find that actually by the 6-minute walk too. If patients not just oxygen, but they are either on the ventilator or they are on another assisted ventilation, what is called non-invasive ventilation, like the CPAP mask, creatinine being elevated, as well as the total bilirubin being elevated. These are markers of right ventricular failure, and patients, they are much sicker. Also, they give priority to certain lung conditions. I mean, because the prognosis and the progression of the disease, I mean, is actually like different in a patient with emphysema rather than patient that they have lung fibrosis. So just to summarize, the patients with lung fibrosis, they're always actually much sicker. So this is from the International Society for Heart and Lung Transplantation Registry, and in this table you can see all the different lung diagnoses, and highlighted in red is for underlying connective tissue disease, in which scleroderma is included. And as you can see, actually, like the number of lung transplants for this indication is very small, and it has not changed over time. And the reasons for that is just because of the persistent reluctancy by several transplant programs to consider scleroderma patients good candidates for lung transplantation. This actually can be a very challenging situation when we evaluate a patient, and particularly if it's a very young patient. As you can see, this is kind of the chest, patient with severe, actually like honeycombing, severe lung fibrosis. But then we get very concerned when we see this dilated esophagus and with fluid levels due to food retention. And then these patients actually, they also have an esophagogram, and you can see actually that hardly the esophagus is moving. That means there's a very actually like a peristaltic esophagus, and evidence also of gastroesophageal reflex. So this has been actually, but particularly the last two, the patulous dilated esophagus and the presence of severe gastroesophageal reflex, which has driven many lung transplant programs to not consider patients with scleroderma being a good candidate for lung transplantation. So we know that patients with scleroderma, they have several challenges, not just as the pre-transplant, but also as post-lung transplant. So the medical optimization of these patients and select the adequate, patient in the selection, that actually like is key for good lung transplant outcomes. In here actually like is some of the things that I have mentioned before that are challenging for lung transplant in scleroderma patients, and I mentioned about the small chest, also the cardiac in patients with pulmonary hypertension. They are usually much sicker when they come to the operating room for the transplant. These patients, they have to be placed, and it can be a challenge for the anesthesiologist on VA ECMO just to support the hemodynamics, and particularly the right ventricle that is so dilated because of the pulmonary hypertension. Also the cutaneous manifestations. We want just to make sure, and that's why the rheumatologist as part of the evaluation is key, just to make sure actually that the skin is not active and is not very thick, and where is the location of that skin thickness, because we don't want actually to be in the area where the surgical excision is going to be. Vascular disease, we want just to make sure that patients that they have rhinos, that is well controlled, and if patients actually they don't have recurrent and it takes a long time to heal some of the digit ulcers. The scleroderma renal crisis, I mean, we are concerned about the possibility of, particularly in patients that have had a history before, and they need to be after transplant on high doses of prednisone, if the scleroderma renal crisis can come back after the transplant. Also, patients with scleroderma, like other autoimmune disease, they have an increase of antibodies, autoantibodies, and that actually can increase the PRA, and patients they can have a challenge getting sooner a good donor match. But also on top of that, if they are women and they have had a lot of pregnancies, that increase more the risk of allosensitization. And here is, like you all know, is all the large, the last arterial diseases or complications, complications that they are associated with scleroderma. And often actually like the concern is that how are we going to manage, these conditions after the lung transplant, because there can be the possibility that they can get actually like worse being in an immunosuppressive state. Also, some lung transplant, some scleroderma patients, they also have some associated underlying connective tissue disease, like scleroderma plus Sjögren or scleroderma and rheumatoid arthritis or myositis. So they have basically what is called this connective tissue disease. And that also increase more some of the challenges of the extrapulmonary conditions associated with this other connective tissue disease. This is in this table is all the published data on the risk factors of poor prognosis in systemic sclerosis, and this can guide some of the rheumatologists and general pulmonologists to make sure that when to refer a patient for lung transplant sooner. But in general, here I have summarized that when early onset of the disease, that is a poor prognosis, like Dr. Mathai mentioned, pulmonary hypertension, and whenever there's a right ventricular failure, pneumothorax, UIP pattern on histology also has worse prognosis than the NSIP pattern. But there's no actually like a percent FM biomarker or clinical prediction algorithm that unfortunately we can use. In 2021, the ISHLT published a consensus on and with updated lung transplant candidacy, and also they focus on the timing of referral in patients for lung transplantation when underlying interstitial lung disease. This was not focused on the scleroderma per se, and they mentioned that at the time of the diagnosis, whenever the patients they start having decreasing the pulmonary function test, showing some restriction, which is typical in patients due to fibrosis, but also how the decline of the pulmonary function test is, and especially if it declines very fast over the last 2 years. Every patient who are on oxygen, either at rest or with activity, when they develop pneumothorax, and also patients that they have an onset of pulmonary hypertension, they are sicker, and these patients, they need to be referred to a lung transplant program, particularly when they have a severe pulmonary hypertension with a functional capacity of 3 or 4, and male, because the prognosis is worse when they are older than 50-year-old, and the presence of pericardial effusion, when they have cardiac involvement, but also a form of pulmonary hypertension, which is the PVOD or pulmonary veno-occlusive disease, because these patients, they are sicker and they don't respond so well to therapy. But also whenever there's a rapid decline, a clinical decline despite maximal therapy. So what has been actually like the data on the outcomes of scleroderma patients, that they have undergone lung transplantation? There are multiple publications, but in here I have just included the most relevant one. The first ones there from the United States, and the last one is from Europe. And one of the things that is important is that we see in here that the outcomes they are very similar. All these studies shows a similar chronic rejection incidence in patients with scleroderma compared with patients with interstitial lung disease not related with scleroderma, and also the short and long-term survival is actually like similar. Some studies shows that the presence of PAH and obesity is a risk factor of poor survival after lung transplant. And the group in Europe also found that they're not just a PAH, but also a female gender, it was associated with a risk factor of poor survival. However, when we review all these studies, we noticed that there were some gray areas, and we found a significant variability observed between lung transplant programs of the selection, evaluation, and listing, and also variability of the GI evaluation among centers and even in the post-transplant management. So that actually open a door of the need to standardize the selection, listing, and evaluation, and the post-transplant management of these patients. And it was created an international working group with an international panel of rheumatologists, which was approved by the International Society for Heart and Lung Transplantation and published. And it has like three parts depending on the different stages of during the lung transplant evaluation to the post-transplant management. And this has been well accepted for the lung transplant community and followed just as a tool guidance in the management of these patients. Also, during this consensus statement, it was, and that was by Delphi voting, it was actually in this table, what was actually like considered the absolute contraindications for lung transplant. And one of the things actually that from the rheumatologic, it was when the patient, they have an active and uncontrolled extrapulmonary manifestations despite maximal therapy. All these actually like unresolvable and complicated GI complications, and some of them that it cannot be actually like even surgically repaired after the lung transplant. Patients that they have an active myocarditis with refractory systolic heart failure despite maximal therapy, unless they are a candidate for a combined heart and lung transplantation. We discussed before about the complicated Raynaud's phenomena that is not responsive to maximal therapy also. And then patients that they have very poor actually like, renal function, and the risk of being on the hemodialysis post-lung transplant is very high. So they are not considered unless patients, they can be candidates for a combined lung and kidney transplant. But however, despite of all of this, there are transplant centers that they still are considering these patients or these conditions, as acceptable for lung transplantation. So the transplant center should determine what risk is acceptable for their center, and that also is it depends on the programs that they have the expertise, and the expertise not just the surgeon. It's just the expertise of the pulmonologist, the other multidisciplinary team, the cardiac anesthesiologist, and the ICU to take care of these patients. So in conclusion, we know that because there's very good data that the outcomes of lung transplant among patients with scleroderma is comparable to the outcomes and the quality of life for other patients with interstitial lung disease not related with scleroderma. We know that the scleroderma patients, they have an increased complexity and extrapulmonary manifestation, which can impact in the lung transplant candidacy and the post-lung transplant outcome. The early evaluation is key because it can identify modifiable risk factors that can influence a patient's candidacy for lung transplant on the lung transplant survival. Let's say a patient comes and the patient we see that is very frail, but other words is a very good candidate for a lung transplant. We actually like, and the patient particular is not so sick, and it has the time to get stronger. Also, patients that they have Raynaud's with recurrent, that is very uncontrolled, or they have recurrent digit ulcers. We can work together with the rheumatologist to make sure that the scleroderma or other extrapulmonary manifestations, they are stable, before the patient can be reconsidered and least for a lung transplant. To optimize lung transplant outcomes is key to get the involvement of a multidisciplinary team in the evaluation and also longitudinal care for these lung transplant patients. The timing of listing, it should be discussed by each patient, considering the factors as the progression of the disease, despite the standard management, expected prognosis, the age, comorbidity, and transplant risk. And also, I mean, even though, I mean, the patients, they have a lot of complexity and a lot of challenges, but each transplant center should determine what risk is acceptable for them. And I want to acknowledge my lung transplant team here at Penn, and I will be happy to answer all your questions. Thank you so much.
Thank you so much again, Dr. Crespo and Dr. Mathai. We definitely appreciate it. And again, Neal, thank you for sharing your story. I know we're a little over time, but I would like to get to some of the questions that we had come in here, if you don't mind. I'll just start with the very first question that came in. Are there symptoms people with ILD can watch for to know if PAH has begun? Is there anyone who wants to take the lead on that?
I can try to answer that. So I'm pretty particular about terminology. So PAH and ILD cannot, by definition, coexist. Okay, so pulmonary hypertension refers to the condition of elevated pulmonary pressures when you have underlying interstitial lung disease. Where there is a gray area is what degree of interstitial lung disease is considered significant. So I just want to make sure we're talking about the same thing, because the management differs based upon how severe the interstitial lung disease is relative to the severity of the pulmonary vascular disease, the pulmonary hypertension. So you got to be careful with that terminology. But in general, it is very difficult to disentangle shortness of breath related to interstitial lung disease versus shortness of breath related to pulmonary hypertension, because they're very similar. There are no real characteristics that I could say, oh, this suggests pulmonary hypertension. The one caveat to that is that when pulmonary hypertension progresses, people tend to get swelling in their legs or swelling in their abdomen. So fluid retention, that type of thing, could suggest evolving pulmonary hypertension. I think if cough is a common or a prominent symptom, that might suggest it's more of an interstitial lung disease, because interstitial lung disease, as it progresses, can cause some cough in addition to shortness of breath. So those might be two subtle things, but it highlights the importance of getting routine checkups to understand, is this related to a progression of interstitial lung disease, or is it evolving pulmonary hypertension?
I see I was on mute. I apologize. Thank you for that answer. And since you were on the mic right there, Dr. Mathai, I was wondering if you could also answer this question directly to you. What level of NT-proBNP do you consider significant, and what do you make of slowly increasing levels? If that's a question that is very specific, that we would...
it's I'm smiling because the top normal values for proBNP differ by lab. So for me to tell you a number that is elevated doesn't necessarily mean in your local lab that number is actually going to be elevated. So the first thing to look at is it elevated based upon your particular local lab? In general, a rising proBNP is something that gets my attention. So I would be looking for other things to go along with pulmonary hypertension. Is that I'm more short of breath, I have swelling in my legs, my echo might look a little different, my pulmonary function tests look a little different. It's not just one thing that's going to make me think this is pulmonary hypertension. It's a lot of things together, but definitely something that catches my attention.
Thank you. Hopefully that answered that question. I would like to shift to some of the questions that we received also during the registration process, and some questions that came in about lung transplantation. One, and I don't know if this is something, Neal, that you've also considered, but Dr. Crespo, what will the quality of life look like after transplant? Will there be immunosuppressants available for life, stuck indoors for life? What is that like after transplantation?
Yeah, I don't think that patients, they have to be indoors for life. They don't have to live in a bubble. The only thing that I can tell you is that obviously yeah, patients, they are going to be, there's not that what is called like a tolerance, to this immunosuppression. So they have to be on immunosuppression medications for life. Some of the immunosuppressions levels, actually, like, or doses might be, as they are far away from the transplant, that might be much smaller. But patients, they can travel around the world, but they have to be more cautious because they are going to be immunosuppressed. So the risk of infections, they are going to be much higher. Patients also, sometimes they might have to change actually some of the things that they were doing before, like scuba diving, or maybe actually like some of the foods that they like, with sushi, they might have actually like to avoid, because we don't want, with raw fish, and not being, it can be a risk actually of contamination and having infections.
Neal, were those things you considered, or was that part of your evaluation process, or just discussing and talking about lung transplantation or transplantation as an option? Have you had thoughts about that?
I have, definitely. Some of the limitations that I saw listed from what I received from the Cleveland Clinic and what I saw on reputable sources online were, avoiding things like gardening, freshly mowed grass. One in particular that caught my attention was wood dust. And as I sit in my woodworking shop right now, that sounds like that would be a no-no. Although I've protected myself really well in my career. I doubt that I could continue this moving forward. So yes, I did consider some of that, but there's the trade-offs of being able to breathe better. Really, it's a I think it's way out for me. I'm in an early evaluation, and so I really don't have my mind wrapped around what would really be like post-transplant on that, but I have considered them, yes.
Yeah, I think it's important to recognize for your own lifestyle what makes sense for you when you're going through the evaluation process and you're hearing the particular stipulations. I would like to point out and note that if you don't already know, PHA has created a podcast called PH Insights, and one of the future episodes coming up in October will review the transplantation process from the patient perspective. So stay tuned for that. You should see that in your email box if you subscribe to PHA Connects. Let's go ahead and answer another question that we received here live. This one is interesting because I'm not sure of what the acronyms stand for, but does scleroderma and PH cause FUI? I'm not sure what FUI is, or if that's a typo. Or maybe it's a typo. So if that person can submit that question again, I'm not sure. Let's go ahead to another question. Let me go back up there. Is there anything that scleroderma, or is that polymyositis patients can do to prevent or slow development of PAH? I'm not sure who wants to take the lead.
I'm not sure, but there are activities that can slow the progression of pulmonary hypertension. I think it's important that people remain as active as possible, because general health of your cardiovascular system, your heart and your lungs, will allow it to perform better, and your lungs and heart to perform better as the pressures rise. What we are hoping is that with earlier identification, earlier treatment, we will minimize the impact of the pulmonary hypertension on the heart and the lungs to allow people to live more normal lives for as long as possible. But I don't know if there's something specifically that can prevent. I mean, obviously things like don't smoke. If you're, exercise and watch your diet, those types of things. But beyond that, I'm not sure there's anything in particular I could point to.
Thank you. Let's move on to another question. We'll do about one or more question after this next one. I know we are pushed for time here. With more telangiectasia have a higher risk of PAH, are increasing telangiectasia, I hope I'm pronouncing that correctly, associated with PAH?
Yeah, there's some research to suggest that that is the case. A couple of studies have shown that an increase in the relative number of telangiectasias over time is associated with pulmonary vascular disease, in particular pulmonary hypertension. It's not a one-to-one ratio. So if you noticed one new telangiectasia, that means you have pulmonary hypertension. It's not that sensitive. But Neal, as I recall, this is something that you noticed.
Yeah, all of it. We can play show and tell.
Yeah, yeah.
And it was all over my face and, part of my chest. And it was obvious to Dr. Julie Pack, who also participated in a study on increased telangiectasia years ago. So
Let me pull in another question here. What do we use to determine the optimal level of exercise, heart rate, shortness of breath, etc.?
that was tough.
I think Marie would agree, if I may speak for us, that pulmonary rehabilitation is a key component, both as part of treatment of pulmonary hypertension, but also in terms of preparation for lung transplantation if someone needs a lung transplantation, and then also rehabilitation after that lung transplantation. So pulmonary rehabilitation is a safe an effective way of determining what levels of exercise are appropriate for an individual. And that's a very difficult thing for a physician to do in a clinic visit, to figure that out. But pulmonary rehab is a supervised exercise program. They're going to monitor your saturations, your heart rate, and observe you during exercise to tell you this is the amount of exercise you should be doing that's going to be effective for purposes of stressing your cardiovascular system, but not overstressing it.
I think a good question to kind of have here to end here, because I think it's something, especially if you're considering transplantation, it may come up in your mind. Can I develop PH again after a transplant? Is that common?
Yeah, so there have not been actually like any cases unless patients, we have seen some patients. There's not much data. I don't know, Dr. Mathai, if you have seen that. There's not much data about, developing actually like the same pulmonary hypertension that patients they had pre-transplant in the post-transplant. There are patients that whenever they develop chronic rejection, that sometimes also they can develop pulmonary hypertension, but also it's as a matter just of maybe the low oxygen levels that they have, like the hypoxia, or if they have had maybe, like a pulmonary embolism, or because they have had for a long time undiagnosed sleep apnea. But the primary pulmonary hypertension that they have pre-transplant is not going actually like to be after the lung transplant unless maybe to disagree.
Muted.
Always muted. I apologize. Any additional thought to Dr. Crespo's comments, Neal or Dr. Mathai?
Yeah, I completely agree with Dr. Crespo. I have not heard of that. I take care of patients after they have had lung transplantation, so I do have an experience in that. I've not seen pulmonary arterial hypertension recur. Interstitial lung disease is rare to recur, and only certain forms will recur. I don't think I've ever seen that in a scleroderma patient in particular. So I think that's not something necessarily we should be worried about.
Thank you both for answering those questions. And again, thank you, Neal, for sharing your story and your journey We appreciate our audience for sticking with us over time here. Again, this recording will be posted to our website on the PHA Classroom. We will also share it out in our PHA Connect newsletter. If you would like more information about scleroderma, you can reach out to the National Scleroderma Foundation at scleroderma.org or email info@scleroderma.org. Again, once we conclude this presentation, there will be a survey that pops up for you to complete. Thank you for taking your time out with us today. We hope you learned something important from our panelists. We will see you next time on the next PHA Live webinar. Thank y'all.
Okay, thank you.
Bye.
Bye-bye.
Take care, everyone.